Dr. Rima Hanna-Wakim. She's an assistant professor of clinical pediatrics at Pediatric Infectious Disease, American University of Beirut at Lebanon. She's currently an assistant professor of clinical pediatrics and pediatric infectious diseases at the American University of Beirut. She graduated from the Lebanese University Medical School in 1997. She started her pediatric residency training at the American University of Beirut and completed it at Sunny Upstate Medical University, New York, USA. At 2004. She completed her pediatric infectious disease fellowship training at Stanford University in California at 2007. She joined the faculty at the American University of Beirut in 2008. She is American board certified in pediatrics and pediatric infectious disease. Dr. Hanna-Wakim's research interests include pediatric infectious disease in general with a focus on antimicrobial resistance and primary immunodeficiency disorders. She's a co-director of the Primary Immunodeficiency Diseases Program at AUB. She's a member of the Infectious Disease Society of America and of the European Society for Immunodeficiencies. She will talk about the multi-system inflammatory syndrome in children at Lebanon, her experience. Donc, Ms. C. Dr. Rima, تفضلي.
Thank you very much, Dr. Menassa. I would like to thank Lebanese Pediatric Society والorganizing بدي اتمنى لكم تكونوا كلكم بصحة جيدة وبعاد عن الكورونا وان شاء الله نتلاقى السنة الجاية بالPS meeting. Before I start talking about multi-system inflammatory syndrome in children associated with COVID-19 disease, I want to share with you like a small anecdote from Dr. Kawasaki. You know Dr. Kawasaki, the Japanese physician who described the Kawasaki disease earlier. So he used to say that whenever he would encounter a patient with a weird presentation that later was described as Kawasaki disease, he would keep the information about the patient in a folder. وكان مسمي الفولدر بالجابانيز وبعدين ترجمها ب one of the conferences God only knows. So God only knows folder turned out later to describe Kawasaki disease. At this point in the pandemic, even though صرنا 1 year in the pandemic, بعد في a lot of questions that do not have answers. Hopefully within the next year or so, we will have more answers about COVID, in particular with pediatrics. So ليش pediatric patient ما بيعملوا severe disease مثل الادلت؟ شو الباثوفيزيولوجي مظبوط؟ شو الجينيتيك predisposition؟ شو in particular كرمال multi-system inflammatory syndrome. So I'll be talking. Okay, how would you advance? Okay, so over the next 30 minutes, we'll be reviewing multi-system inflammatory syndrome in children. Several definitions that we'll talk about. I'll be talking about the MISC spectrum of disease and how it is different from Kawasaki, and then the current management and treatment. So في part من presentation that was presented earlier by Dr. Mahfouz, so I go over it quickly. This is from the dashboard from Johns Hopkins University. As you know, so far we have more than 102 million cases globally with more than 2 million deaths. This is as of today. In Lebanon, we have at this point around 296,000 cases with mortality that has been increasing recently to around 2,680. If we look at the data from the Ministry of Public Health, you can see in this graph, this line, the orange line, showing the incidence rate in children. And you can see that recently we are seeing some increase in the rate or the incidence of COVID-19 infection in pediatric patients between 10 to 19 years. As for the mortality, as Dr. Mahfouz mentioned and showed you, we do not have, thank God, significant mortality in pediatric patients. We have a total of 9 patients who are less than 19 years old, and all of them have underlying comorbidities. Okay, so what happened? We started hearing about COVID-19 infection back in December last year, and then by January, and then progressively there were like those case series coming from UK, Italy, France, and then the US. So the first case series came from Evelina London Children's Hospital in mid-April, where they described 8 patients who were previously healthy and who all of a sudden came to the emergency room with what looked like hyperinflammatory syndrome. They looked either like atypical Kawasaki, shock with Kawasaki, or toxic shock syndrome. All patients at that point had negative RT-PCR. Remember, in the initial data, we did not have availability of antibodies on a regular basis. So this was for the UK paper. And then subsequently from Bergamo, that was the epicenter in Italy, they published also a paper in the Lancet describing 10 children who were 3 to 16 years old who looked also like severe Kawasaki-like syndrome. 2 had RT-PCR positive for SARS-CoV-2, 8 had positive antibody, and 2 patients had negative PCR and negative serology. A third paper came subsequently in Circulation describing patients from France, 35 patients who had also a median age of 10 years, and 2/3 of the patients required mechanical ventilation, and 10 patients out of these 35 required ECMO. Subsequently, another paper from France published in BMJ described that those patients who presented with this hyperinflammatory syndrome tended to have more GI symptoms and had more hypotension. And interestingly, from the France study, most of them were of African ancestry. So this is where it started with the UK describing in April 26th their experience with the 8 children. And this is the Bergamo study and then later the French study. So directly after the description from the UK, the RCPCH, which is the Royal College of Pediatrics and Child Health, came with guidance, and they described their syndrome as pediatric multisystem inflammatory syndrome temporarily associated with COVID-19. 14 days later, data from New York, and at that time, New York was the epicenter of COVID-19 in the US. There were 2 papers published in New England Journal of Medicine describing cluster of patients who presented few weeks following the pandemic peak with what looked like the syndrome that was described in the UK. The CDC published an alert, and they published case definition in May 14, 2020. Subsequently, European CDC and WHO published their own guidance about this hyperinflammatory syndrome. So there are currently 3 main names for this syndrome. The RCPH, or the UK call it the PIMTS. The CDC call it MISC, multisystem inflammatory syndrome in children. WHO call it multisystem inflammatory syndrome, inflammatory disorder in children and adolescents. So I'm going to go quickly over the definition, and I'll focus later on the CDC definition. So for the UK definition, they define it as a child who is presenting with persistent fever, and note they do not precise how many days of fever, with inflammation, and by inflammation they focus on elevated neutrophils, elevated CRP, and lymphopenia, and having evidence of single or multi-organ dysfunction, so cardiac, respiratory, GI, or neurologic, with additional features. And these may include children who are fulfilling full or partial criteria for Kawasaki. In the criteria, they make sure to remind us to exclude other microbial causes, so we don't want to miss the bacterial sepsis, staph or strep shock syndrome, other infections that are associated with myocarditis, like viruses, mainly enteroviruses. But with a big reminder that you should not wait for full investigation to delay seeking further advice and further workup. The SARS-CoV-2 PCR testing may be positive or negative. So this continues to be at this point the UK definition. The CDC definition is more specific. So they specify having an individual that is younger than 21 years. And recently there has been reports since July describing this multisystem inflammatory syndrome in adults. So they call it MISA. It is not well defined yet, but like a big alert went out from the CDC to alert internal medicine physician and family physician about this new entity. So an individual who is younger than 21 years old with fever, in the CDC, it's more than 38 for just more than 1 day, lab evidence of inflammation, elevated ESR, CRP, fibrinogen, procalcitonin, ferritin, D-dimer, IL-6, neutrophilia, lymphopenia, and low albumin from all the inflammation. and evidence of clinically severe illness requiring hospitalization with more than 2 organs involved. And this can be any organ. The main organ is the heart, but it can be renal, respiratory, hematologic, GI, dermatologic, or neuro. And no alternative plausible diagnosis, and positive for current or recent SARS-CoV-2 infection, either by RT-PCR or by serology or by antigen test, or even having negative testing, but close contact with exposure within the previous 4 weeks to someone with COVID-19 infection or even with suspected COVID-19. In addition, some patients may fulfill full or partial criteria for Kawasaki, but those patients should be reported if they fulfill the case definition of MIS. Also, what the CDC warns about is considering MISC in any pediatric death with evidence of SARS-CoV-2 infection. And they recommend that any pediatric death within the pandemic that seems related to infection or inflammation to have an autopsy in order to know the exact cause of death. Now, the WHO, as I mentioned, toward mid-May, put an alert about the...
Dr. Wakim, your voice is cutting out a little bit.
They put an alert about the multi-system inflammatory syndrome. Their definition is slightly different, so their age group is 0 to 19 years. And the fever is more than 3 days, but they continue to have clinical signs of multi-system involvement, at least 2 of the following: having rash, bilateral non-purulent conjunctivitis, similar to what happened with Kawasaki, mucocutaneous inflammation, swelling of the hands and feet, hypotension and shock, and features of myocardial dysfunction, being pericarditis, valvulitis, coronary artery abnormalities, evidence of coagulopathy with prolonged PT-PTT and elevated D-dimers, and evidence of acute GI manifestations. In addition, elevated markers of inflammation that I mentioned. In addition, the 5th category, no other obvious microbial causes of inflammation, so no bacterial sepsis, staph, or strep shock syndrome, and evidence of COVID-19 or likely contact with COVID-19. So these are the 3 definitions. They are almost overlapping in the both in the CDC, WHO, and in the UK guidance. They remind you that include patients who have features of typical or atypical Kawasaki or toxic shock syndrome to consider them in the work. Now, this is a table from an article by the American College of Rheumatology clinical guidance describing what I said, like the difference between RCP, UK, CDC, and WHO data. So most of them, they overlap, with CDC having more details, a little bit of more details. Now, so let's go over what is this MIC, why is it different from an acute severe COVID-19 infection? If you look at acute COVID-19 infection, as Dr. Mazdalani mentioned, most cases happen in children, result in very mild to moderate disease, and those patients do not need to be hospitalized. So in acute COVID-19 infection, patients who were sick to go to the hospital were ill children who had comorbidity. And as Dr. Mazdalani mentioned, main comorbidity are obesity, cardiac, pulmonary, neuro. One of the main comorbidity that is gaining attention now is having Down syndrome, even in the absence of cardiac involvement. So patients with Down syndrome are at high risk of significant morbidity and mortality with acute COVID-19 infection. So in acute COVID-19 infection, you're going to see in the hospital children who are sick with comorbidities and mainly with fever, cough, sore throat, GI symptoms. Severe illness is less frequent, requiring PICU admission, and most of the PICU admission will be related to hypoxic respiratory failure. And this is different from MISC. Sorry, Hada Fatah al-Bayt. Oh, okay. So this is different from MISC. In MISC, the data are showing that patients are previously healthy. They present usually with fever, GI symptoms, hypotension, shock, Kawasaki-like features, and they tend to be admitted to the PICU due to cardiovascular involvement rather than respiratory failure. They tend to have a delayed presentation after 2 to 4 weeks from the pandemic, indicating that this is a post-infectious process. Now, what about the epidemiology of MISC? The incidence at this point is uncertain, or I should say unclear yet, because we have to look back at the data. We know that it is a very rare complication of COVID-19 infection, and this is important to mention to the families and the parents. This is very rare. It occurs in around 1 to 2 per 100,000, and these are data from the US. It might change with time, and it might change in different ethnicity or in different patients' backgrounds. So time will tell us, and we'll have to see what will happen over the next few months. We know that the estimated incidence of lab-confirmed SARS-CoV-2 in individual less than 21 is around 322 per 100,000, and this is data from the US, from New York. The estimated incidence from data from New York was around 2 per 100,000. We know very well that there is this temporary relationship with a COVID-19 infection, and this was described in several papers. This is from a paper from France, running from March 2nd to June 21st. They had around 195 patients with MISC in the country, and you can see this shows the number of COVID hospitalization, and exactly around 2 to 4 weeks following the peak of COVID pandemic in the country, they started seeing increased case of patients, of children presenting with MISC. And you can see that some of these patients had unknown COVID history. So even if you see a patient with suspected MISC where the PCR is negative, antigen is negative, antibodies is negative, it could still be MISC if he fulfills the criteria. Other studies have showed that 30% in one of the New York study had negative PCR and serology. So this is another paper showing the temporary relationship of COVID-19 infection in the community with the MISC. And you can see this is from New York between March and April. In blue are the COVID-19 cases, and in red are the MISC cases. And you can see after the peak of COVID-19 infection, they started to see the peak of MISC. This is also from New York, from another center, where they looked at a total of 186 patients. And this is data from the CDC that included New York and other states. So they looked at 186 cases back between March and April of patients who fulfilled the definition criteria of MISC. Their median age was around 8 years. Most of the patients were males. And you can see in the graph how the incidence of MISC increased several weeks following the COVID-19 pandemic rise in the community. So I summarized some data from the CDC. This was last updated early January. So in the US, they have a total of 1,659 patients. This is in all states, reported from 47 states, with 26 mortality secondary to MISC. Some studies have reported a mortality between 1.5, 1.4 up to 2%. If you look at the age group, so it tends to happen, we will have a peak in patients between 5 to 9 years old. We continue to see in older kids in 10 to 14 and 15 to 20. And as you can see, we have a male predominance more than girls. Also looking at data from the CDC to try to establish what are the risk factors. So who are the patients who are going to develop MISC? From what we know so far, those are healthy individuals with no significant comorbidities. Data from the US show that more than 70% of patients were Hispanic or Latino, followed by Black non-Hispanic patients. So they tend to see less Asian patients, which is different from what we see in Kawasaki. There are ongoing studies now at several centers at the NIH, in the US, and in Europe, looking at risk factor for MISC, and mainly looking at genetic background. As you know, there was a paper published in Nature back in, I want to say June, where they looked at the genetic risk factors in patients who had severe COVID-19 infection. This was not MISC, only severe COVID-19 infection. And they found that 20% of patients who had severe COVID-19 infection or more had alteration in the interferon or interferon gamma receptor. So we don't know yet. Studies are ongoing to look for what are the genetic backgrounds of those patients. Is it going to be similar to Kawasaki, where you have a genetic predisposition, then a trigger that will trigger your immune and inflammatory system? So I'm going to move to describe the spectrum of disease of MIS-C and to see how is it different from Kawasaki. One of the main criteria or main thing that we should be alert for as a critical feature for MIS-C is the impact on the cardiovascular system. And this is from a paper from the CDC. Almost 80% of patients with COVID, with MIS-C presented with any type of cardiovascular involvement. The most common were mild tachycardia and normal echocardiograph, but remember, and look at this, 50% of patients had elevated troponin, 73% have elevated pro-BNP, and most of these patients did not have at that point respiratory involvement. In this particular study, 91% of the patients underwent echocardiography, and very interesting, more than 38% of the patients had an ejection fraction less than 55%. 5% had ejection fraction less than 30%, less than 5%. So remember, those are healthy children who were doing well, normal, and then all of a sudden they had the fever and this inflammatory process and decrease in the ejection fraction. 12% had dysrhythmia, and around 48% of patients required vasopressor support, required inotrope support and ICU admission. So this is important for us to remember and to be on alert whenever we see a patient with, during the pandemic and during the peak now, with unusual fever and inflammation. Now, what is the impact on the other organs? And this is according to the age. So you can see GI manifestation, we tend to see vomiting, diarrhea, sometimes hepatitis, very rarely pancreatitis. We tend to see gallbladder hydrops, and this reminds us of what we see in Kawasaki. In Kawasaki disease, some patients will present with gallbladder hydrops when you do an ultrasound of the abdomen. Hematologic, we tend to see more coagulopathy, more risk of DVT or pulmonary emboli. In terms of rash, we tend to see any type of rash similar to what we see with Kawasaki. Later on, you might see more rashes related to vasculitis, like the rashes of Henoch-Schönlein line purpura. Respiratory, some of these patients will have some fluid overload, and you might see infiltrates or pleural effusion. You might see some patients presenting with cough. Musculoskeletal, very few patients had elevated CPK with myositis, arthritis or arthralgia, and we are seeing more arthralgias following MIS-C in the first few weeks following MIS-C. Neurologic, so with the neurologic manifestation, the most common is alteration in the mental status, but with the inflammation, but you might see other manifestations that I will discuss in the following slide. Kidney, we're seeing a mild acute kidney injury. Most of the time it is reversible. So for the coagulopathy, as I mentioned earlier, we see DVT, pulmonary emboli, bleeding. And remember, this is not with the acute COVID-19 infection, this is subsequent. With the neuro, aside from the altered mental status, you may see stroke, encephalitis, Guillain-Barré, ADEM, seizures, brain edema. Cardiac, as I mentioned, impairment of cardiac muscle, and later on coronary artery aneurysm, arrhythmia. And GI, the severe bowel inflammation that we usually do not see with Kawasaki disease, along with abdominal pain, diarrhea, and ileus. Now, if we look at the lab markers of these patients, and this is from the New England Journal of Medicine paper that came out in May or June. So if we look at the lab, we're seeing a lot of lymphopenia and neutrophilia. And the neutrophilia and lymphopenia are more prominent in older children. Anemia, secondary to the inflammatory process. Low platelet count is observed, sometimes below 100,000, and this might put a challenge regarding initiating aspirin. Elevated D-dimer, elevated fibrinogen, elevated INR, low albumin, elevated CRP, ferritin, and ESR, increased troponin, and increased pro-BNP with evidence of hepatitis also. This is a cartoon from a paper in Circulation describing acute heart failure in MISC patient. And you can see in this, the red text are what we see typically in Kawasaki, and the black is what we see rarely in Kawasaki. So we tend to see in patients with MISC and Kawasaki, sometimes bulbar conjunctivitis with limbic sparing. Neuroscience are more present in MISC. Left ventricular dysfunction is more present in MISC in contrast to Kawasaki, where we tend to see more coronary artery dilatation and pericarditis. And digestive problems, so GI manifestation, as I mentioned earlier, more in MISC. This is another cartoon from Contemporary Pediatric, a review looking at the difference between MISC and the regular Kawasaki that we used to see. The first main difference is in terms of age. So patients with Kawasaki would present at mean age of 2 years, whereas with MISC, we tend to see older kids presenting with MISC. In terms of ethnicity or race, patients with Kawasaki, at least in the US, we tend to have Asian or Japanese background, would be at higher risk, whereas current data from MISC is showing us that we tend to see it more in African, patients with African heritage, whether it is from the France, UK, or the US data. The other manifestation is the severe GI symptoms that are more prevalent in MISC, and the severe myocardial dysfunction and myocarditis. Whereas in Kawasaki, we tend to see more coronary artery aneurysm. And we tend to see higher abnormalities of coronary artery in Kawasaki shock syndrome. Acute kidney injury is more prevalent in MISC, elevated pro-BNP and troponin. And remember, before the COVID-19, we did not choose to test a lot with the pro-BNP and D-dimer in patients with Kawasaki. So we do not know if in regular Kawasaki you will tend to see more elevated pro-BNP, but the troponin is definitely more in patients with MISC. More inflammation with high ferritin, high triglycerides, and high CRP, to a point where sometimes we are concerned if there is, in addition to MISC macrophage activating syndrome, we tend to see more thrombocytopenia. And data is showing that most of these patients will have normalization of the platelets as they recover. In contrast to Kawasaki, where like 2 to 4 weeks after recovery, you would see thrombocytosis. Lymphopenia is more prevalent, and the association with low LV, low left ventricular ejection fraction. Okay, remember also, so this is a nice review just to keep in mind that they might overlap. So you might have MISC plus Kawasaki features in the context of a pandemic plus recent exposure or recent infection with SARS-CoV-2. Now, what is that pathophysiology? Again, it's not well understood yet. We know that there must be genetic predisposition plus a trigger that will trigger the immune and inflammatory system. There are abnormal immune response to the virus with some clinical similarity to KD, to Kawasaki disease, sometimes to macrophage activating syndrome and to cytokine release syndrome. The immunophenotype is somehow different from Kawasaki disease and MAS. And as I mentioned, the hypothesis is that there is some immune dysregulation underlying that occurs after the acute infection has passed. So this is also a cartoon from Trends in Cardiovascular Medicine showing the connection between genetic predisposition, a trigger, and cytokine storm. Just something to mention that there were some data back in the late 90s looking at Kawasaki disease, and one paper in particular from Northwestern looked at connection with coronavirus, and in that particular data, they found coronavirus particle in the coronary artery biopsy and in autopsy. So there's definitely a trigger related to the virus. Now, this is an interesting paper, although it mentions only a limited number of patients. They looked at mapping systemic inflammation and antibody response in MISC. So they had 9 patients, aged between 3 to 19. 6 of these patients had evidence of COVID-19 infection by RNA, by PCR. 9 had evidence by serology. Most of them had GI issues All of them had cardiac abnormalities, and all of them had elevated inflammatory markers. And in all patients, the timeline between the infection and the MISC presentation was around 4 to 5 weeks. What they did, they took a blood test and they compared to other patients who had COVID-19 infection. Their limitation is they did not compare to healthy control. So all of these 9 patients were healthy. They compared to patients who are immunocompromised or who were in the hospital with comorbidities with acute COVID-19 infection that was relatively mild to moderate requiring hospitalization. So further testing comparing to healthy individuals from the community with COVID-19 infection are necessary. And they tried to look at the system level immunoprofiling assays on these 9 patients. This happened in New York in late April to March. So in the same set of patients that were described in one of the papers, and most of the patients were Hispanic. So what they found is that if they look at the antibody repertoire, it resembles a convalescent response. They looked at the cytokine profile, and the cytokine profile indicated, they looked at more than 70 inflammatory cytokine and chemokines. It indicated myeloid cell chemotaxis and mucosal inflammation. They looked also at immunophenotyping, looking at more than 85 markers, and they showed that there was immune cell activation and egress of the immune cells toward the periphery. What is interesting is that they found a lot of autoantibodies that are targeting organ system, and they think that this is central to MISC pathology. So both the cytokine profile, the immunophenotyping, and the autoantibodies. More data are needed to better give us an idea about what's going on in the immune system, and then looking back at what are the risk factors for patients to develop MISC.
Dr. Wakim, please, 10 minutes.
Okay, I will run quickly. So I'm going to run to tell you that there are 3 spectrums of phenotype. So there is the phenotype where you have MISC without overlap with acute COVID-19 or Kawasaki disease, overlap with severe acute COVID-19 infection, and overlap with KD disease in 30%. The incidence of coronary artery abnormality was similar in the three subgroups, ranging from 16 to 21%. Now, what's the current management? And I'll go over it quickly. There are very nice review from the American College of Rheumatology to look at that. I need to move to plug my computer. So if you follow with, and this is interesting, the diagnostic pathway. So if you have a patient presenting with what looks like MISC, they recommend to go over and do tier testing. So not to do all the testing directly. So you look at the patient, he has fever, epidemiologic link to SARS-CoV, at least 2 of the suggestive clinical features, rash, GI, edema, oral mucosal changes, conjunctivitis, lymphadenopathy, neuro. If he doesn't have them, look for something beside MISC. If he has them, so have other causes that could explain the presentation being considered. So make sure there is no bacterial sepsis, there is no strep or staph sepsis. Then you start the investigation for MISC. Is the patient in shock? If he's in shock, if he's hypotensive, tachycardic, poorly perfused, directly go and do the tier 1 and tier 2 labs. I'll go over them now. If he's not in shock and he looks stable, we can start a tier diagnosis evaluation. And this is important also to go stepwise in patients who are not very sick. So the tier 1 would include doing a CBC, complete metabolic panel, ESR, CRP, SARS-CoV-2 PCR, and or serology, and look at the results. If you see in the results significant inflammation, significant elevation in the CRP, ESR, lymphopenia, thrombocytopenia, hyponatremia, neutrophilia, and low albumin, which are indicative of inflammatory process, then you go and you do the tier 2. And the tier 2 will include the more sophisticated, more expensive tests, including procalcitonin, PT-PTT, fibrinogen D-dimer, LDH, and triglycerides. In addition to cytokine profile, if you have access to it, we tend to do IL-6 and troponin and proBNP. And these are very important. So you go and do tier 1 and tier 2 if you have a patient who fulfills the criteria and who's in shock. Otherwise, it's better to go with tier 1, and then once you have the result, if there's significant inflammation, move to tier 2. Now, What is the treatment that we will offer to those patients who have suspected or confirmed MIS-C based on the case definition? You're going to see several treatments, and I'll go over the American College of Rheumatology guidance. So in this paper from the CDC, most patients received IVIG. Some required a second dose IVIG, but there's a warning now not to give a second dose, to move directly to systemic steroids. There is more and more use of IL-1 receptor inhibitor, anakinra. Tocilizumab are left for more severe patients, and in that case, you need to consult with the rheumatology before starting it. And systemic anticoagulation. 80% of those patients required to be in an ICU setting. 48% required vasoactive support. 20% required mechanical ventilation. They had in this paper 2% mortality. And most patients recovered very well and were discharged with no complications. Now, what is the management? It's very important when you see a patient with suspected or confirmed MIS-C, you need to have two decisions. The first decision, where are you going to treat the patient, in an ICU setting or in a regular unit? And this is easy in the ER. And the second most important part is having a multidisciplinary case. And this is very important. So you need to have your intensivist on board, of course, the ED if they are around, cardiologist, you need to have the hematologist, the rheumatologist, and of course, IT. So you start by, there are 4 sectors that we're going to discuss quickly. You need to manage the shock plus the cardiac management. We'll discuss briefly what we do with antibiotics and antiviral. Immunomodulatory treatments is very important, along with antiplatelet and anticoagulation. So for the cardiac, also, if the patient presents with shock, you need to resuscitate as per standard protocol for children. So fluid resuscitation, inotropic support, respiratory support, very rarely ECMO. Remember not to overload them with fluids as before you do the echocardio to make sure they don't have low ejection fraction. You need to follow troponin and proBNP. Do EKG at least every 48 hours. They might need continuous telemetry, halter later on. An echocardio need to be done at the diagnosis and then during follow-up, looking at ventricular, valvular dysfunction, pericardial effusion, and looking at coronary artery dimension with D-score. Echocardio should be repeated at minimum 7 to 14 days after diagnosis if the patient is doing well, and then at 4 to 6 weeks, and then at 1 year, or depending on the cardiology if they feel there are more concerns. If you have LV dysfunction and or coronary artery aneurysm, so you need more frequent echo. There are data about using cardiac MRI later on in patients who have significant LV dysfunction, or if they had at presentation, or if they continue to have persistent LV dysfunction. So this will be decided with you and the pediatric cardiologist. Regarding antibiotics and antivirals, so if the patient looks sick, if you have suspected confirmed MIS-C with what looks like septic shock or cardiogenic shock, remember to add empiric antibiotic spectrum just to cover for possible bacteria until you have an idea. So usually you may give ceftriaxone, vancomycin if you have suspicion of Staph aureus. If the features are more suggestive of toxic shock syndrome, and this is in more adolescent and young adults, you need to add clindamycin. Data so far is showing that the rate of bacterial co-infection is low. Antibiotics should be re-evaluated daily, and you
2
should
minutes, please. 2 minutes.
If you want me to stop, I can stop, but there are more. There are like 3 more slides, I think.
If you can, in 2 minutes, it's okay.
So antiviral is decided on a case-by-case basis to discuss with the ID. For the immunomodulatory, rule out other possible infections and non-ID etiology before initiating immunomodulatory treatment. For patients who have mild symptoms, you may observe. Otherwise, you may use a stepwise progression of immunomodulatory therapy, like a tiered approach. You start by using IVIG 2 grams per kilo. Remember, IVIG should be, the dose should be based on ideal body weight, and remember to assess fluid status and cardiac function. If the patient is in shock, in addition to IVIG, use methylprednisolone at 1 milligram per kilo per day. If it's not responding, you may increase your methylprednisolone and give a pulse therapy. If the patient is not in shock, you may give IVIG 2 grams per kilo and observe. If you feel that the patient is becoming refractory, and you need to ask.
Juliana, thank Rima. Only on the questions will be answered in writing. We have to move on for time's sake.
So the management of pediatric patients with regarding the immunomodulatory treatment, you need to follow up lab and cardiac assessment to guide immunomodulatory treatment. You may require to slow taper the steroids, so don't stop them directly, wait until 2 to 3 weeks. As for the antiplatelet and anticoagulation, the recommendation is to start low-dose aspirin, maximum 81 milligram, until normalization of platelet and confirmed normal coronary artery at 4 weeks. Avoid aspirin if there is active bleeding risk, and or thrombocytopenia. If you have coronary artery aneurysm with Z-score more than 10, you need to continue low-dose aspirin plus therapeutic anticoagulation. The recommendation, aside from dilated coronary artery and coronary artery aneurysm, for therapeutic anticoagulation is documented thrombosis and low ejection fraction. And the recommendation for longer outpatient therapeutic anticoagulation are if you have a Z-score more than 10, documented thrombosis, and ongoing moderate to severe LV dysfunction. The majority of these patients, as I mentioned, will recover. There are systematic review looking at more studies in terms of mortality, and as I mentioned, it ranges from 1.5 to 2%. So the take-home message, first, it is a rare complication of SARS-CoV-2 infection. So this is very important in order to reassure your families and parents. It is temporarily associated with SARS-CoV-2 infection. Please rule out other infectious or non-infectious etiology. And for diagnostic studies, we talked about the labs, imaging. If there is a need, you may do an LP. Have a low threshold for hospital admission, even if they are still under investigation. So if you have abnormal vitals, respiratory distress, neurodeficit, or altered mental status, mild renal or hepatic injury, markedly elevated inflammatory markers, abnormal EKG, pro-BNP, or troponin. And what's very, very important is include a multidisciplinary team. If you work in a hospital where you don't have a pediatric intensivist, make sure to include your adult intensivist and your adult cardiologist. So on board, you should have the intensivist, the cardio team, ID team, rheumatology, and hematology. And with time, the understanding of the full spectrum of MIS-C hopefully will be more clear. It is evolving, and it will give us a better idea about the different phenotypes, the different subphenotypes, and the different managements. Thank you very much.
Thank you, Rima.
ثانك يو دكتور ريما. بعتذر انه وقفناكي كذا مره بس لانه اخذنا وقت حتى ما نصير على الوقت الثاني. في كثير سؤالات وكلهم يعني كلهم حابين نسالهم بس لانه ما بقى في وقت رح نعوق للاخر. رح نمرق على 9 الصبح.
Okay, thank you.